Have you ever felt just completely buried under, articles, research papers, conflicting data,
Ah, absolutely.
and you're just wishing someone could hand you the really essential, trustworthy bits?
That feeling of needing to get informed quickly, but like genuinely informed.
Exactly, without drowning in just the sheer volume. Well, that's kind of our mission here today.
Right.
We want to give you that shortcut, focusing on some really robust and crucial tools in research, the ones that cut through the noise and give reliable answers.
And today we're tackling systematic reviews and meta-analyses.
Yes. And why are these so important?
Well, fundamentally, they represent the highest level of evidence we have in clinical research. Seriously, top tier.
When you hear a big claim about what works best in medicine, chances are it's been through one of these.
Or it should have been.
Yeah.
They're kind of the ultimate fact checkers for scientific literature.
And to help us demystify these powerful tools for you, we're drawing on insights from two key pieces.
Yeah, we've got Schwar's systematic reviews. What do you need to know to get started from 2015?
And that really detailed PRISMA statement for reporting systematic reviews and meta-analyses by Liberati and colleagues from 2009.
So we're going to do a deep dive, unpack how they work, what makes a good one.
And, crucially, why knowing about them helps you evaluate the information you see every day.
Let's jump in.
Okay, so, systematic review. It sounds, well, pretty academic, maybe a bit intimidating.
It can sound that way.
For us trying to get reliable info fast, what's the core idea? How is it different from just, grabbing a bunch of articles on a topic?
Right. What's really fascinating is that a systematic review isn't just collecting studies. It's a meticulously planned investigation.
Planned how?
It aims to find all the available evidence on a very specific, clearly defined topic. And it uses explicit, systematic methods.
Okay.
The whole point is to minimize bias and get the most reliable findings possible from that whole sea of studies out there. Think of it like top-level detective work for research.
I like that detective work. Okay, so if that's the systematic review, the big umbrella, what about meta-analysis?
Ah, good question.
People often use them interchangeably, right? Is that correct? Or is there a key difference?
Yeah, that's a common mix-up. They are definitely not interchangeable, and getting that distinction is really key.
Okay.
So systematic review is a whole process. The rigorous searching, selecting, assessing evidence for that specific question.
The whole detective job.
Exactly. A meta-analysis is a specific part of some systematic reviews. It's the bit where they use statistical methods to combine the numeric data from the individual study.
Ah, so combining the numbers.
Right, to get a single summary result.
Yeah.
But importantly, not all systematic reviews can do a meta-analysis. Maybe the studies are too different.
Okay.
But all systematic reviews must use those strict systematic methods to find and summarize the research, whether they combine numbers or not.
Okay, so I think I'm getting it. The systematic review is the whole rigorous process, the search, the appraisal, and the meta-analysis is like one specific tool within that process, a statistical tool that lets you combine the numbers if the studies are similar enough.
That's a perfect way to think about it. The systematic process is the foundation. Meta-analysis is an optional statistical layer on top when it makes sense.
Right, okay. That structure seems critical for reliability. So how do these research detectives even start building this case? It
Well-
begins with a blueprint, right? A plan.
Exactly right. Just like any solid research, it all starts with a crystal clear clinical question. That's job number one.
If the question is fuzzy.
Your answers will be fuzzy. Simple as that.
So how do they make sure the question is clear enough for this huge task?
Well, they often use a specific format called the PICO format.
And key O.
Yeah, PICO. It stands for patient, intervention, control, and outcome.
Okay. Can you give an example?
Sure. Let's say you're looking at a new diabetes drug. Your PIC might be
Yeah.
patients with poorly controlled type 2 diabetes. That's P. Intervention. Gliptins, the drug class. Control. Placebo. And outcomes. Maybe change in A1C and how many hypoglycemic episodes occurred.
I see. Patient, intervention, control, outcome.
Exactly. And Sharor really stresses this. You have to define these parameters a priori.
Before you start.
Yes, before you even begin searching. If you don't, you run into big problems later trying to decide which studies fit. It's like setting the rules of the game before kickoff.
Okay, that prevents moving the goalposts later.
Precisely.
That sounds a bit like defining who gets into a clinical trial. So once I have that sharp question, what's next? Deciding which studies get in.
That's step 2. Clear inclusion and exclusion criteria. Just like deciding which patients get into a trial, You decide which studies get into the review.
And these are also set beforehand.
Absolutely. Defined right at the proposal stage.
Yeah.
They cover things like study design. Maybe you only want randomized controlled trials, or perhaps other designs are needed. Language, like maybe only English language studies. And specific outcomes, are you looking at hard clinical endpoints, like death or heart attack, or just surrogate markers?
And these criteria link directly back to the PICO question.
Directly. They keep the review focused and prevent bias from creeping in when selecting studies. They're the boundaries of the investigation.
It really sounds like a huge amount of planning happens before they even look at a single study abstract.
Oh, it is.
Why is all that upfront work, the protocol, maybe even registering the review, so important?
Think of the protocol as the detailed architectural blueprint. It spells out exactly what they plan to do, why, and how, all before they start.
Okay.
And that's critical because it locks in the methods. It helps stop what Liberati calls biased post hoc decisions.
Meaning
Meaning you can't tweak your methods or analysis plan just because you've seen some early results that you like or dislike. It keeps it honest.
right. And registration?
Registration, putting the protocol in a public database, adds transparency. It also helps stop multiple teams doing the exact same review without knowing it.
Ah, avoids duplicated effort.
Exactly. And it can help combat publication bias, which we'll probably get into later. It just makes the whole research landscape more open.
Okay, so they've got the sharp question, the strict criteria, the detailed plan. Now the treasure hunt begins, finding all the relevant studies.
Yep, now the search. And Sherwal makes a great point. The quality of a systematic review is only as good as the data on which it is based.
So the search has to be good.
It has to be thorough and complete. You can't just do a quick search in one database.
How many?
Definitely more than two. And you need to go beyond just Medline, which is, a common starting point, but not enough on its own.
Who helps with that? It sounds complicated.
This is where a skilled librarian, especially one with expertise in systematic reviews, is absolutely invaluable. They're like the master navigators.
Helping with search terms and strategies.
Exactly. Defining complex search strategies to catch as much relevant research as possible. It's far beyond a simple keyword search.
Okay. Now, I've heard this term gray literature. It sounds kind of shadowy. What is that, and why bother finding it? Seems like extra work for obscure stuff.
It is extra work, but it's really important. Gray literature is stuff that isn't published through the usual commercial academic channels. Think reports, theses, conference papers, maybe government documents.
Why hunt that down?
Because of publication bias. Studies with splashy, positive, statistically significant results tend to get published more easily than studies with null or negative findings.
Ah, so if you only look at published stuff.
You might get a skewed picture. You might only see the studies where the treatment looked great and miss all the ones where it didn't work or had issues.
So you're only getting half the story.
Potentially, yes. Finding gray literature helps counterbalance that bias. Reviewers also do things like hand-searching the reference lists of included studies and checking trial registries. It's about turning over every stone.
Wow. That sounds incredibly exhaustive. So once they have this mountain of potential studies from everywhere, how do they fairly decide which ones actually make the final cut? Who guards the gate?
Right. This is study selection. And to ensure fairness and minimize bias, it must be done independently by at least two researchers.
Two people, separately.
Yes. They both apply the predefined inclusion and exclusion criteria to each potential study.
What if they disagree?
They discuss it. If they still can't agree, they usually bring in a third researcher to arbitrate.
Okay.
And crucially, this whole process, how many studies they found, how many they screened, how many they included, and why others were excluded, needs to be documented.
Ow.
Ideally, using a flow diagram, like the Prisma flow diagram. It gives you, the reader, a transparent trail of how they got to the final set of studies.
Okay, so transparency is key there. They've searched, screened, selected. Now they have their final set of studies. The ingredients are gathered. What data do they pull out?
This is data extraction. And just like selection, it should also be done independently by two team members.
Same reason. Reduce errors and bias.
Exactly. Using standardized forms helps ensure consistency. Sometimes they even blind the extractors.
Blind them? To what?
To the authors of the study the journal is published in, maybe even the results, although that's harder. It's another layer to reduce potential bias.
And what if the studies are unclear or missing info?
Good reviewers will often try to contact the original study authors to get clarification or perhaps even unpublished data points. It's about getting the details right.
Okay, this next step feels critical. assessing the quality or reliability of the studies they've included. Because even if you find all the studies, some might be better conducted than others, right?
Absolutely. And this is an area where the thinking has evolved. We used to talk broadly about study quality.
And now?
Now the focus is more specific, assessing the risk of bias. The key question is, did the original studies minimize bias in their design and conduct? It's about internal validity.
Internal validity, how trustworthy the study's own findings are.
Precisely. The Cochrane collaboration, a big name in this field, has pushed this shift. They have a tool that looks at specific potential sources of bias.
Like what?
Things like, was the randomization process truly random and hidden from those enrolling patients? That's allocation concealment. Were patients and researchers blinded to who got the real treatment versus placebo? Was follow-up complete, or did lots of people drop out?
So digging into the methods.
Deeply. This approach is harder than just using a simple quality score. But Charrois notes it provides more valuable information. It focuses on what the researchers actually did, not just what they reported doing.
That distinction feels important. What they did versus what they said.
It's crucial for really understanding if a study's results are believable.
Okay, so they've searched, selected, extracted data, assessed the risk of bias in each study. Now what does it all mean? When can they actually combine the data statistically in a meta-analysis?
The big decision point.
Yeah.
Whether to meta-analyze really depends on whether the studies are similar enough.
Similar in what way?
Were the outcomes measured in a similar fashion and reported consistently? Like our A1C example earlier, if all studies measure that, you can probably combine it.
But if some measured A1C, others measured blood sugar differently.
Then combining them might be like comparing apples and oranges. Exactly. You also need to look closely at the patient populations, the specific interventions used, the study methods. Are they comparable? This is called a qualitative assessment of heterogeneity.
Heterogeneity. Differences between the studies.
Exactly. And there's software like Review Manager or RevMan from Cochrane. That helps with the analysis if you decide to combine the data.
But what if the studies are just too different? Too much heterogeneity, apples and oranges?
Then a meta-analysis should not be considered.
Yeah.
If the studies vary too much in patients, interventions, outcomes, methods, combining them statistically doesn't make sense. It could give a misleading average.
How do they measure that difference?
There's a statistic called the I-squared, or I. It quantifies the percentage of variation across studies that's due to heterogeneity rather than just chance.
So a high I-squared means?
High I-squared is a red flag. It signals significant inconsistency, suggesting that maybe you shouldn't pool the results. You might just present the studies individually.
Okay. Now, what about those missing studies we talked about? Publication bias. How do they look for that across the whole set of studies?
That's assessing the risk of bias across studies. Reviewers actively hunt for clues of missing studies, which is publication bias, or even missing data from the included studies, which is selective reporting bias.
How can they spot potentially missing studies?
One common tool is a funnel plot. It plots each study's effect size against its precision, usually related to sample size.
And what should it look like?
Ideally, it should look like a symmetrical inverted funnel. Lots of small studies scattered at the bottom, fewer larger studies clustering near the average effect at the top.
And if it's lopsided?
Asymmetry, like a chunk missing from one side, especially at the bottom where small studies live, can suggest publication bias. Maybe smaller studies with negative or null results just weren't published. There are also statistical tests, like Egger's test, to formally check for this asymmetry.
Okay, that's clever. Can they dig even deeper into the data, do other kinds of analyses?
Oh, yes. They often do additional analyses to explore the data further and check the robustness of the findings.
Such as?
Sensitivity analyses, basically rerunning the analysis while changing certain assumptions or excluding specific studies, like those with a high risk of bias, to see if the main result holds up.
Stress testing the result.
Exactly. Then there are subgroup analyses, looking to see if the treatment effect differs across specific groups. Maybe it works better in older patients or those with more severe disease.
Useful for tailoring treatments.
Potentially, yes, though these need to be interpreted cautiously. And meta-regression, which tries to quantitatively link study characteristics like dose or study duration to the size of the treatment effect.
Wow, lots of ways to slice the data.
But crucially, Liberati emphasizes reviewers should plan these additional analyses in advance and report all of them, not just the ones that show something interesting or statistically significant.
Why report everything?
To avoid selective reporting bias within the review itself, you need to present the full picture, warts and all.
Okay, so they've done all this incredibly hard work. searching, selecting, extracting, assessing bias, analyzing, checking for missing studies. They have their findings. How do they tell the world in a way that's clear, transparent, and trustworthy for readers like us?
That brings us to reporting.
Yeah.
And the gold standard here is the PRISMA statement.
PRISMA again.
Yes, preferred reporting items for systematic reviews and meta-analyses. It's essentially an outline, a guide, detailing what should be included in a published systematic review.
What does it cover?
Everything from the title and abstract, through the methods, results, discussion, right down to funding information. It's a detailed 27-item checklist and a 4-phase flow diagram.
So it's like a quality score for the review. A good review follows PRISMA.
Ah, that's a common misconception and an important point. PRISMA itself explicitly states it's not intended as a quality assessment tool for the review.
Oh, then what is it for?
It's for ensuring transparent and complete reporting. It guides the authors to lay out everything they did, step by step, so that you, the reader, have all the information needed to judge the quality and trustworthiness for yourself.
I see. It's about giving the reader the tools to evaluate it, empowering the reader.
Exactly. Full transparency.
So what are some of those key things PRISMA says must be reported for that transparency?
That flow diagram we mentioned is crucial, showing the journey of studies, how many were found, screened, assessed, included, excluded, and why.
Following the breadcrumbs.
Precisely. Also, table summarizing the key characteristics of every included study, the PFO elements, basically. And another table detailing the risk of bias assessment for each individual study.
So you can see which studies might be weaker.
Right. If there's a meta-analysis, you need forest plots. Those are the graphs that visually show each study's result and the overall combined result. Very powerful visual summary.
I've seen those.
And then, of course, the discussion needs to clearly summarize the main findings, assess the overall strength of the evidence, discuss limitations.
Limitations are important.
Absolutely. Honesty about limitations, whether in the included studies, the review process, or a potential reporting bias, is critical for building trust. And they should discuss the relevance to different groups, like clinicians or policymakers.
Okay. So how does it all wrap up? What's the final takeaway?
Reviewers need to draw clear and balanced conclusions that are directly tied to the findings. They shouldn't overstate the evidence. And they should consider the implications for future research, what gaps remain.
And funding. You mentioned that earlier.
Yes. Transparency about funding sources and the role of the funder is item 27 on the PRISMA checklist. It's critical because funding can, unfortunately, sometimes introduce bias. Knowing who paid for the review helps you interpret the findings.
Right. Full disclosure. Okay, well, that brings us towards the end of this deep dive into systematic reviews and meta-analyses.
It's been a journey through the process.
Definitely. We've seen what they are, these really robust, rigorous tools designed to synthesize tons of information into trustworthy insights.
Hopefully you now have a much clearer picture of all the steps involved. That detailed planning, the exhaustive searching,
Including the gray literature.
yes, and the critical assessment of bias, not just quality. And finally, how transparent reporting using things like PRISMA lets you evaluate the final product.
And knowing all this, it really does empower you, doesn't it, to look at health claims, research news.
Absolutely. You can start to ask critical questions. You're not just taking claims at face value. You understand the immense effort behind high-level evidence.
So maybe a final thought to leave everyone with. The next time you see a headline about the best way to treat something or the latest scientific breakthrough,
Tell you for a second.
yeah, pause and just consider.
Yeah.
How thoroughly was the evidence actually reviewed? Did they look everywhere? Did they account for bias?
Are we getting the clearest, most complete picture possible? Or just maybe half the story?
Asking those questions, that's a powerful tool in itself.